Hi, everyone. Welcome to our Flash Talk number 6, where we'll be talking about various examples of integrating digital services in healthcare systems. My name is Adrian Aguilera. I'm a faculty at UC Berkeley and UC San Francisco. And I'm excited about this topic because I do think that in order for digital mental health to have real impact, we have to find ways to integrate these tools into the care that people receive. And there are various ways, obviously, to disseminate digital mental health interventions, but this is a key one, in my opinion. So I'm excited to have our presenters today. We're going to give folks about 5 minutes to present. Feel free to pop any questions you have in the chat, and then we'll have a couple minutes after each talk for questions. I'll be keeping time to make sure that there's enough time for all presenters. So first we have Keke Schuler, who will be presenting on the development of a clinical decision support tool for digital mental health intervention referral in primary care. So take it away, Keke.
Thank you. Good afternoon, everyone. I'm Keke Schuler. I work as a mixed methods researcher at Reliant Medical Group, OptumCare, and I have my colleague Sam and Brittany here who will present as well. So I'm going to share my screen. Let's hope this works. The double screen is always a little bit tricky for me. Can you guys see this? See the slide?
Yes, you're good.
Okay, thank you. So yeah, today I'm going to talk about the development of a clinical decision support tool for digital mental health intervention referral in primary care. Just very briefly, a little bit backgrounds. We are kind of in this little in a gap here. We see a lot of primary care providers are talking about BH related concerns with their patients, but our providers are not feel equipped with clinical knowledge to really address these concerns. So one of the possible solutions we think that can help our primary care provider is to develop eligibility flag, which is a clinical decision support tool that will help flag patients to whether they are eligible for a care model that matches them to a digital mental health intervention. So today I'm just going to briefly talk about how the methods we used to develop this eligibility flag. So we used a very broad approach initially to look at different data sources that may feed into our eligibility flag. So we have semi-structured interviews we did with our behavioral health integrated clinicians who have been referring patients to this digital mental health care first model for over a year at the time of the intervention, at time of the interview. And during this interview, the data we collected allowed us to identify some clinical clinical factors, and as well as some logistic factors that may be useful to kind of set up the parameter for our eligibility flag. We also reviewed historical electronic medical records to see for those patients who have already been referred to digital mental health intervention, what are some things that pop up in their medical chart. We also used PHQ-GAD, clinical cutoff scores, as one of our parameters because it's patient often complete those questionnaires with their visit. So after we collected all the data sources, we kind of triangulate and see which is more prevalent or more important for our patients who have already been referred to digital mental health intervention. And from there, we developed an initial criteria about our eligibility flag, and we use the iterative process to testing. So basically, we have a criteria set and we implement it into our electronic medical records, and then we collect data over the period of a week or so, and then using that data to cross-check against patient criteria who are actually using digital mental health intervention, and see where the criteria is missing. Is it diagnosis? Is there certain criteria where we're cutting off cutoff scores too high or low, something like that. So we keep refining and improving our criteria. At the end of the day, so our final criteria feed into our eligibility flag are diagnosis codes. So you can think of certain, we are excluding certain diagnoses, for example, schizophrenia, bipolar disorder. We're also including certain diagnoses, depression, anxiety. We have PHQ and GAT, certain cutoff score we used for our flag, and also we have identified certain elements in medical records that's allowed us to flag patients who may be at risk for suicide or self-harm. We also eliminated anyone who are active substance or alcohol use or currently enrolled in therapy. All those things are allowed us to are being identified in the medical records. So by the end of the day, before we launch our eligibility flag in primary care, our specificity is about 93%. So basically, but our conclusion is the eligibility flag exceeds the clinical specificity guideline that support PCP in identifying eligible patients for digital mental health intervention referral. And also we see it's very effective and it's help providers feel this self-efficacy about referring people with PH concerns, and also enhance our adoption in primary care. That's it. Thank you.
Really cool. I'll get back to the room.
Hi, I have a quick question. So apologies if I missed this, but how will this exactly work? Is this like a program that you will give to officers for them to utilize within their office, or is this information that is going to be shared between you and offices? And I ask that because of data sharing and patient privacy.
Yes, so it's not something we shared. It is a best practice alert that's built in the medical records that basically directly draw information from medical record. For example, Brittany come to the PCP's office and she has a PHQ score of X, and she has a diagnosis of MDD. And based on those information that's already existed in the medical records, the flag, it meets the criteria to show up the flag. The flag recognize, okay, Brittany is eligible. And then it was when Brittany comes to the office, it will show up and say, oh, Brittany may be eligible for digital mental health intervention. And PCPs can look at this and decide whether to offer this or not, and make a clinical discussion with the patient to go either further or not. So it's nothing about, no data is shared, it's directly drawing from information that's being already hosted in the medical record.
Okay, thank you.
I also have a follow-up question.
Yes.
So, yeah, so given the nature of the mental health paradigm, so I'm come from the world of interoperability. So when you have these questionnaires like PHQ-9, you have this Hamilton depression, you have the Yale Brown questionnaire, you have some schizophrenia questionnaires. So I worked with them, so given the landscape, so right now it's free for all. So given the terminology systems that are underlying those, so if you're getting a questionnaire that is using a Loing code, somebody using a SNOMED CD code, sort of, so to speak. So how do you do sort of the semantic interoperability? Do you do that, or you just rely on one standard or assume it? Because at the end, a consumer, how do you render those questionnaires? Are they just one standard, or do you, because the nature varies. Anybody can use whatever they want. And
Yeah.
that's one question. Second is,
Well, I think we only have time for the one, so maybe we
Okay.
can get that. You could
Yeah.
maybe you can email offline for the
Yeah, I have a email here, so feel free to email me. But to answer your question, so we have long story short, we have certain elements that's standard. For example, PHQ and GAD, those are standard for patient to complete, but we also have element in the flag. For example, the diagnosis code are more broadly and can be used in other scenarios or in other medical systems. So that's a short answer. I'm happy to explain more, but feel free to email me. Thank you.
okay, good, thank you.
Thank you very much, and thanks for that question. Great. Next, we have Brittany Jaso, who will be presenting on evaluating the impact of a digital navigator on increasing patient registration with digital mental health interventions within routine care. Take it away, Brittany.
All right, thank you. Can everyone see the screen okay? Perfect. Well, hello, everyone. I'm Brittany Jaso. I'm a research manager with Reliant Medical Group, which is part of OptumCare. And I'll be discussing how we evaluated our digital care navigator on increasing patient registration with digital mental health interventions. So I don't need to tell this audience how wonderful digital mental health interventions are. And so instead of focusing on all the positives that I think many of us are aware of, I'm going to focus on one of the drawbacks, which is, unfortunately, if you build it, they may not come. A lot of patients have difficulty taking that first step in registering with their mental health intervention. In one study of participants in a remote research study for that had apps for depressive symptoms, almost 58% of patients never even downloaded the study app. A more recent study has shown that only 60% of patients tend to register with their interventions. And so a lot of time and effort has gone into making these interventions. The problem then becomes, how do we capitalize on patient enthusiasm for treatment seeking and get them the help that they need? So one of the proposed solutions that we use to this new challenge is to create a role specifically designed to serve as the go-between for patients and their digital mental health interventions. So we created a non-clinical role called the Digital Care Navigator, whose sole purpose was to provide technological assistance to our patients, which frees up time for our referring clinicians to do what they do best and focus on assessment and diagnosis and figuring out the best treatment for patients. To briefly give you an overview of the patient flow, at the time that we had pulled this data, a primary care provider may identify a patient with behavioral health needs and would refer a patient to one of our behavioral health integrated clinicians. These clinicians would meet with patients for 30 minutes to determine eligibility for digital mental health interventions. And if they determined the patients were a good fit, they would refer patients to the appropriate mental health intervention. However, it doesn't stop there. Our clinicians don't say, here's your treatment, best of luck, see you in 6 weeks. Instead, we created a new role, that Digital Care Navigator, whose sole purpose was to then take a warm handoff from the clinician and help the patients become more comfortable with their intervention. And the Digital Care Navigator did a number of different things. He showed patients how to register, how to create an account with their therapeutic. He helps with any sort of technological difficulties, walks patients through how to set up their devices if they had any sort of devices, and sometimes even helped patients figure out how to find their Wi-Fi password or set up their Wi-Fi so they could engage with their treatment. Within the first 8 months that we had deployed the DCN, a single DCN, he made 1,306 phone calls to 680 unique patients, successfully connecting with 66% of those patients. What's more incredible is that we noticed almost immediately that registration rates increased significantly between pre-implementation of the DCN and post-implementation. So median registration rate increased from 61% to 76%. So our digital care navigator was helping more patients register with their intervention. Moreover, what I think is also fascinating is that we learned that the latency by which the DCN outreached our patients had a very strong impact on the likelihood of registration. So if a DCN was able to get in touch with a patient the same day as their referral from their clinician, the likelihood for registration was almost 97%. Even a one-day delay in outreach resulted in a 76% likelihood of registration. And by 5 days, the likelihood of registration fell to almost 42%, showing that not only is it important for us to be matching patients with the right intervention, but we need to capitalize on that referral, on that momentum to help patients get in touch with their care sooner. And so what did we learn from this? Our DCN is a wonderful person. He increased registration rates for our DMHIs. He helped patients get access to evidence-based care faster. And something I wasn't able to discuss, but through their effectiveness, they helped shape the digital ecosystem and workflows. So moving forward, we now have a team of DCNs. And thinking about future directions for how this non-clinical role can be implemented, we're looking towards the future, past that registration point, and maybe leveraging that connection the DCN makes with our patients to then encourage engagement with the treatment following registration. Thank you.
Thank you so much, Brittany. We have time for a question if somebody has one.
Yeah, I'm Will Weaver. This is really interesting. We've played around with the DCN idea. How do you guys pay for it? And could you potentially train like someone who's already in the integrated primary care system to do this role?
That's a great question. So all of our funding comes from OptumCare. And so we had funds to create this position. I think, so one of the reasons we wanted to be very intentional with who we hired for this role, and we'll be publishing a white paper a little later about the qualitative aspects that we thought were important. But one of the main things we wanted to make sure is that this was not a clinical role, because we didn't want to blur the lines between the referring clinician and the person who is there to set up the technological aspect. And so when you're thinking about maybe changing roles for someone who is already in that position, I'd just be very mindful about if they have a clinical background and if that conversation may drift too much into clinical territory and less into the technological helping aspect. But I certainly think that it is possible.
Great. There was another question that was similar, so I think you covered it. One more that came up. What are the training resources used for the DCN?
So we are incredibly fortunate. Our DCN, our original DCN, is just a go-getter. And so they shadowed clinicians to understand the clinical workflow process. They received a little bit of training about professional ways to interact with patients, and they had to learn how to write notes in the electronic medical record. So there was a lot of shadowing, but then the DCN himself really took the reins and created his very own manual that he has now shared with everyone else that we have hired to support him. It's been a lot of just learning as you go and pivoting. And so you really need a go-getter when you're starting this role for sure.
Great. Thank you so much, Brittany.
Thank you.
There are a few other questions, but if you want to contact Brittany, it looks like the email is on the screen. Maybe you could pop it in the chat too if you'd like.
Thank you.
Okay, great. So next we have Chris Miller, who will be presenting on the integration of a fully automated digital CBT treatment for insomnia in clinical workflows at the Henry Ford Healthcare System. Chris, are you there?
Hi, thank you very much. I'm just having difficulty sharing my slides because of an access issue.
I'm not
I don't know if there's any other way around it.
I'll try this, see if this works.
Thank-
You want to see if that, I just made you the co-host, see if that works.
It's still asking for a privacy issue.
It might be on your end, maybe a settings issue.
I find that sometimes with Zoom on settings, if you don't have, there's a setting about sharing that can be switched, toggled on and off, and it can make it so you can't share your screen. I've run into that a lot in classes I teach.
Yeah,
Yeah,
I think it's
doesn't let-
probably an internal setting.
Adrian,
Um,
if you want me to go,
Yeah, that's what I was gonna
uh,
say.
Okay,
I'm
thank
Maybe
happy
you.
to
I'm
do
gonna
that
go to
while we
Sam
work
and
out.
Chris if you can go. It might be in your privacy settings or something.
Thank you.
All right.
All right, and this makes some sense since this will help to round out Keke and Brittany's presentations. So I'm Sam Nordberg. I'm the Chief of Behavioral Health at Reliant Medical Group. You get my slides shared. You guys can let me know if you can see them. Looking all right?
Yep.
Okay. So I'm here at a higher level to answer that question more broadly of how do you pay for this stuff? And so a couple of things to frame. Reliant Medical Group, about 50% of our patients are in full global risk capitated contracts, meaning that we're at risk for their medical and their behavioral spend. A quick overview of the whole precision behavioral health initiative. So Keke and Brittany were speaking about some aspects. So identification of appropriate patients through the eligibility flag, right? Then we screen with a multidimensional computer adaptive questionnaire, which actually gives us matching criteria that are clinically derived for the different tools that we have in our curated ecosystem. So we have an ecosystem of about a dozen different proven tools at this stage. And each one of them has particular selection criteria that are driven off of this multidimensional assessment. That allows us to pick what we believe is the right tool for the right patient. And then we have under all of this a learning health system that allows us to evaluate whether we made the right choices or not, and then evolve our algorithms as we move forward so that we're doing a better and better job of connecting the right patient with the right thing. This is far too brief of an overview, but I wanted to give you a little bit of context here. What I'm going to be talking about is, and just really quickly, our outcomes are good. So right now, our outcomes on about 3,000 patients stand at about the 65% clinically significant improvement rate, which is substantially better than what we see in our ecosystem for psychotherapy for similar patients. So I want to run through today, though, some early numbers that we're getting as we look at claims. So we have claims data on a more limited set of patients that we have run through this model because we get claims on our capitated patients. And so a couple of interesting things that we're noting. So the top table is related to engagement in psychotherapy. So really looking at the key CPT codes for psychotherapy. And what we're looking at here is the difference between patients who declined the program. They were appropriate for it, Keke's flag fired, we offered it to them and they declined, meaning that we referred them on to treatment as usual, which is psychotherapy, versus those patients who engaged in the program and either completed the full course of treatment or dropped out after some dose of treatment. And this is important because we find actually that in that completed bucket and the dropped out bucket, the percentage of patients who are clinically significantly improved is roughly equivalent, meaning that those dropped out folks got what they needed and then stopped. And we'll come to that in the next slide. But what we expected here was that those declined patients should cost more than the patients who opted in, because the patients who opt in aren't going on to get psychotherapy later or aren't getting it concurrently. And indeed, that's what we see on psychotherapy spend, that 6 months after referral, the psychotherapy spend is much higher for those declined patients than it is for those patients who engaged in our program. Now, are there differences between these patients? For sure. Do we know what they are? For sure we don't, but we will be looking into it as we think about future directions. And all this data is either observational or correlational. So I want to be clear. at this point, we're just speculating as to what's driving these things. Then we also looked at total medical expense. And here we pulled in another group because we wanted to have something that helped us to maybe avoid a little bit of the selection bias between looking at people who were offered our program and declined it or accepted it. So here we took a historical look at 3,500 patients who, according to Keke's flag, would have been eligible. But because the program wasn't up and running for them yet, were never offered care, versus those who were offered and declined, and then those two groups I talked about before who at least got some dose. And what we see here is when we look at their total medical expense, what we see is that those members who engaged in precision behavioral health have lower total medical expense for the 6 months that they're engaged with the program, versus those who declined or those who were eligible but were never offered the program. Now, again, this is all observational, and it's difficult to draw any conclusions from this. The next slide, I'm attempting to draw a little bit of directionality as we look at whether patients were clinically significantly improved in the program versus patients who had no improvement or for whom we had no data on their improvement. And here what we start to see is an interesting observed difference, that those patients who did improve, for whom we have claims data on 6 months, their total medical expense is lower than this blended group, or indeed when we split this group apart into no data or no improvement, the trend remains roughly the same. Now, again, this is not suggesting that improvement is a driver. We haven't looked at that yet, but it is a promising indication that what we may be doing here is getting patients improved at a lower cost compared to traditional psychotherapy, and that those improvements may in fact be driving their total medical expense. It's also entirely possible that patients who selected precision behavioral health were also the patients who are more likely to improve on their own. And we've got a lot of work to do in order to figure this out in the future. Limitations, right? The subset of patients that we had claims data on was not completely at random. We haven't done any significance testing or directionality testing yet. Our ends are still relatively small. I mean, 250 patients isn't terrible. But as we accumulate more data faster, we're going to get much more clarity on this. And obviously, we want our post-spend to be evaluated at a 12-month period, not just 6 months. It's just that with claims lag and rollout, it takes a while to accumulate that much data. So I'm going to stop there, and I think I have time for one question.
Thank you so much for that. Questions from the audience?
I'd have a question, Sam, if you guys are tracking any aspects about why people are declining the digital treatment when it's offered.
It's largely what I call the goodwill hunting effect, which is they think they need a therapist and no one can tell them otherwise.
Thanks.
Yep.
Great.
Time for another question?
Yeah, if somebody has a quick question. All right, what are some of the next steps in this work, Samuel?
I mean, it's largely at this stage scaling so that the amount of data goes up by an order of magnitude or two. We're starting to use machine learning to look at patient digital phenotyping and using digital phenotypes to match better with the right tools. But in terms of feeling confident about our outcomes data, we're there more or less. And so we're in the process now of spreading to care delivery organizations over the next 12 months. We'll be covering about 1 million more primary care patients with this tool. So that's going to give us a lot more of the scale data. Reliant has 350,000 primary care patients. So a lot of the next step is building that scale and then using that data as rapidly as possible to continue to improve on the quality of our recommendations, as well as to spread our data-driven recommendations up the chain into more complex mental health challenges and matching to appropriate treatments for those as well.
Great, thank you so much. All right, I think we're gonna try Chris again. Let's see, there we go, we're on.
It didn't work this time. Apologies for the delay, but thank you. And so I'm Chris, and I'm going to talk about the integration of digital CBT for insomnia into workflows in Henry Ford Healthcare System. And so I'm an employee of Big Health, and Big Health build digital treatments for insomnia, anxiety, and depression too. And these are fully automated treatments that don't require a therapist to support. And cognitive behavioral therapy is the first line recommended treatment for insomnia per guidelines around the world. This has been the case for some time now. And Sleepio is a digital cognitive behavioral based treatment that's fully automated, provides access for patients to all of the skills, techniques, behavioral interventions, cognitive interventions that you'd expect from therapist-delivered CBT for insomnia. And over the last 12 years, we've studied its effects of Sleepio in clinical trials, economic evaluations, and within different healthcare settings and populations with different patients as well. Because of this evidence base, we've been recommended or cited in the following guidelines, and we have rolled out Sleepio at scale within healthcare settings here in Scotland. And through this experience, we now want to take these implementation results that we've had with our rollout in NHS Scotland, where now over 60,000 patients have had access to Sleepio. And our uptake has been, as we would expect, where people live across the regional variations within Scotland. We now want to take these learnings and try and apply them to the US healthcare system as well. So we selected to partner with Henry Ford Health because we have a long-standing research relationship, and we had an observational cohort study that we used a real-world evaluation for as part of this approach. And what we wanted to do was to evaluate the use of Sleepio in clinical practice within the academic internal medicine clinic and the sleep clinics to find out the best way to build a workflow that would help with providing access to digital CBT for patients. And we use normalization process theory as a framework to help embed digital CBTI. And this basically means making low changes that don't impede the clinical workflow, so you're not getting in the way of patient care. And really, we're trying to solve for long wait times at the sleep clinic to see the therapist, the only therapist there, and improve patient choice and reduce reliance on second-line medications for insomnia. So about June last year, we started to embed our the clinical workflow processes within the Epic system, and I've got an example slide on that next. And then we rolled out training to the AIM clinic, the internal medicine clinic, and then to the sleep clinics as well later on. And then we scaled up our data flows so that we were able to match patients for their Sleepio information to their chart information at Henry Ford Health. And then we used that data to provide feedback back to the clinicians and provide more training opportunities as well. And this is an example of the changes we made to the Epic order flow process. And here you can search and assign the dot phrase .sleepio. This would then automatically generate an after visit summary. It would be sent to the patient MyChart if they have that app, and then they can access Sleepio directly from within their phone or mobile app. And then from this, we also provide access for folks that don't have MyChart to a paper-based flyer that would provide access to Henry Ford Health, and then would have this in referral stations around the clinical settings as well. So patients could access this when in conversation with a clinician. And this is our uptake rate based on the number of orders from Epic in blue over time for the first 38 weeks, and then mapped to the trainings that we had here as well. And then this is the uptake rate from the Sleepio here as well. So the uptake rate was 40% and it maintained over time, but it could be better. And we think this is because there are other things that are occurring at the management visits as well. So patients were also being referred to CBTI and they could receive medications too. This is a snapshot of the patient sample at the end of May 2024, whereby we had over 1,200 folks that had an order for Sleepio. The average age was about 54 years. Most folks were female and had an insomnia diagnosis with further medical conditions as well, and were managed with medications too. So the key learnings were that normalization process theory really enabled these low-lift, non-disruptive changes to the workflow, and they didn't get in the way of the clinical setting, and they allowed patients to access Sleepio. But most of the folks were actually from the sleep clinics where insomnia was managed the most, with a minority from the AIM clinic where physical health conditions were managed. Some of the clinician feedback was positive and some was constructive, whereby they liked the order flow process, but they would have liked reminders as well about the access to Sleepio, how it's spelt at times, and then to be reminded in staff meetings as well. And really the next steps for us are to explore further integration with behavioral health teams where mental health is managed more at Henry Ford Health, and then also more within primary care where at family physician level, insomnia is managed the most. So thank you to everybody involved, the patients, the clinicians, and those at Henry Ford Health. And thank you for listening to. I'd be happy to take any questions you may have. Thank you.
Great, thank you, Chris. We have time for a question or two. I can start. I'm curious if you had any, if there was any kind of digested information given to providers based on the participation in the with the app or data from that, anything like that.
Yeah, so our trainings were built and we looked to provide the clinicians at the start of when we rolled out Sleepio. But as we go through time, more clinicians became involved and some left. And so we need to make sure that we refresh those training schedules as well. And we stay on top of this too, so that we're always integrating and making sure that people know about access to Sleepio and that you know, it's top of mind when they're actually seeing a patient with insomnia as well. So having onboarding for clinicians when they begin at the practice, I think would be important. And then maintaining and refreshing that throughout time is also important as well. So we were exploring ideas around having somebody on the ground that could help initially to provide, you know, signposting about access to Sleepio here too, but there might be other ways that we could do this as well.
And do the clinicians see any of the data kind of on the back end in terms of how patients are doing?
We haven't provided a mechanism for that at this time. So that is something that we could do next, whereby we would have a way of providing that information back to the specific clinician. But that is something that we can look to do going forward.
Great, thank you. All right, we're on to the next, and I believe, yeah, the last presentation by Simon Goldberg, utilizing AI to assess multicultural counseling skills. Take it away, Simon.
Hey everyone, my name is Zach. I'll be presenting for Simon. Oh no, of course. This is work Simon led, so it's nice that you mentioned his name. And so I'm really just talking about an initial step in a process we've been utilizing to start to help build some trainings and assessment tools for different therapist skills. So this presentation, a little bit different than some of the earlier ones. We're talking about building digital tools to support the practice of low-tech humans talking in a room, or I guess like this. And so disclosure, I'm a co-founder and minority shareholder in Listen, and a lot of this work I'll be describing today was funded by the John Templeton Foundation. So the basic problem we're working on is that it's all of the communication that you have with your patients that matters. That includes things like empathy, listening skills, but in the mix with that are key multicultural skills. How do you navigate the cultural differences that you encounter in everyday clinical practice? And how do we learn those skills and assess them? And those are the things that matter. Traditional ways of doing that are either client self-report, which is used sometimes and can be helpful, but the gold standard, which is not used very much, is observing people doing counseling-like behaviors and rating them for what they're doing. And that is extremely labor intensive. It tends to be really slow, and it also tends to have reliability problems. And utilization of that in large-scale efforts to train workforce really just don't scale up and aren't used in any realistic way of helping the workforce grow. And so what we've been working on with collaborators are ways of using AI to build tools that can scale that feedback. So instead of just watching some slides and maybe watching some role plays, you get a little bit of clinical information, you get some practice experiences where you're talking with a standardized patient, and then you get immediate feedback on the skill you used, and that feedback has been shaped over time by ratings from real human coders that have been trained using state-of-the-art large language models, but whatever it happens to be at the time, machine learning. So what I want to talk about here today, and just briefly, is our initial effort to validate some of the machine learning algorithms that can allow us to give that sort of feedback. So here is that project where we did an initial paper seeing if we could automate the recognition of multicultural counseling skills. And so what we did was recruit around 100 undergraduate and graduate students from professional mental health training programs. We showed them 8 different culturally diverse clinical vignettes. We had a rating scale that's also been published that I could send to folks, assessing different domains of multicultural orientation. Those included things like cultural comfort, humility, and opportunity. For example, opportunity is about if there is an opportunity to discuss a cultural topic, does the provider take it? Do they follow that with the client and allow them to have that conversation? We trained 9 human coders to manually label a little over 600 of those responses to some level of internal agreement. And then we used a transformer model using standard validation splits to replicate those human ratings. And here is the initial results from that project, where overall our average was a Spearman's row of 0.75, which is pretty good, but you can definitely see that there is some variability in performance here. For aspects of humility and comfort, we just weren't as good as others. And so we're engaged in scaling up the amount of human responses we have right now to try and get more data to improve this before we release it, because the project and next steps here is we have built the training platform and we are getting ready to release an initial stage of this for an ongoing study, looking at if we can really train people, give them quick feedback, and improve their multicultural counseling skills quickly using this sort of technology. So thanks for listening, and I'll stop there.
Thanks so much. Questions for Zach? So there's a question in the chat. Could this be used with non-specialists, folks without a behavioral health degree?
I mean, that's a great question. It certainly would be one that we'd want to look into. My off the cuff answer to that is we built this without assuming that you had any knowledge of what multicultural skills are. And so we don't start with a bunch of jargon. We start with very formative ideas around the idea that this could be used for folks who are more like peers and coaches and things like that, where this could be an initial training for folks across a variety of different spectrums in the mental health workforce.
I don't know if fellow panelists are allowed to ask questions, but I'm going to ask
Please
one
do.
anyway, Zach, if that's cool.
Sure.
Are you guys looking at this as also a possible way of vetting and validating some of the AI designed sort of therapist bot style interventions?
That's a great question. And we have had conversations with folks who have reached out to us according to those things so far. And it is certainly a thing that could be done. I mean, I have a couple of reactions to that where the types of errors that a bot makes are probably not going to necessarily be the same ones that a human makes, and the things that you might worry about. But that doesn't mean it couldn't be an initial useful screen for different types of behaviors. And so I think it's a great idea.
Zach, there's another question in the Q&A. How does the system measure cultural humility or comfort? Can you give some examples?
Well, let me take one of them. And so I think this will actually give some insight into why humility, or maybe I'll pick comfort, is harder. It has a clear behavioral anchor in the coding manual where you're looking for, how can I demonstrate it? So if I was to respond to your question by, well, I mean, that's a good question, but so that would show some low level of comfort in responding to the question. I have some disfluencies, maybe I'm a little anxious, I'm a little halting. those behaviors are more in the music than the words sometimes, which can be more challenging to pick up because humans have a harder time rating that reliably. And so we do capture that sort of information. We're not just using transcripts, we're using other sorts of metadata in the response the person generates. But a general rule of thumb is if you can reliably have two humans agree on a thing, then you can do pretty well with machine learning on it. But sometimes these skills are pretty nuanced. And so we're going to have more data, I think, to do as well as we want to.
Great. And there's one more question in the chats. We have a little bit more time. Would be curious to see metrics on the cross-cultural validity of the coding scale. Also, is the standardized patient a live streaming avatar?
On the latter one, I'm not exactly sure what means by live streaming. The current ones I was showing you are pre-recorded vignettes, and we just record a bunch of them. And so they're not live in any sense of the imagination. We have another randomized clinical trial running right now that is using a generative AI client bot. And so I guess you could think of that as a live streamed experience where you don't know what the bot's going to say from talk turn to talk turn, but we've created profiles where they have a general sort of tendency to respond in different sorts of ways. And so we have a variety of different types of situations. But then the cross-cultural validity of the particular MCO scale is a great question. And I think there's a lot of work to do on general observational systems of multicultural skills. How do they work across different therapist cultural groups, but also client cultural groups?
Great. All right. Any other questions from the audience? Okay. Well, I want to say thank you to all the panelists. I think these were all wonderful examples of ways, and quite diverse examples of ways that digital mental health, not only interventions, but navigation and training tools can be integrated into care. So it was wonderful to see, learn from, and look forward to seeing the continued development of these various products. So thank you all, and thank you to all the attendees and participants. Hope you have a great rest of the conference.